Good morning. I'm sorry, I apologise for my French in advance. I've been interested in tyrosinemia for the last 24 years, so it is a true privilege to be asked to speak in what is the home of tyrosinemia. And I'm going to present a similar but different experience because, as somebody already alluded to, in the United Kingdom, which has a very well-developed health service, those in power feel that screening for tyrosinemia is not appropriate. So, or not indicated thing. So most of the patients that I see with tyrosinemia have been presented clinically. And I think, as you can see, once they develop liver disease, they're in a different situation. We can never go back completely to where they were beforehand. And again, we are trying very hard to change that paradigm, and that I hope, before I retire, that screening for tyrosinemia, universal screening for tyrosinemia, will be copied from Quebec to the United Kingdom. I'm going to concentrate on the liver aspects of tyrosinemia, and as you've heard, it's a multisystemic disease, but three components to that. The most dramatic presentation, and the one that we see here, and the one that I guess you used to see here as well, is liver failure. Then those who have chronic liver disease, and in the longer term, this very high and unique in paediatric liver disease, this uniquely high risk of developing liver cancer even during childhood. In Birmingham, we've treated 35 children with nitisinone over the last 24 years. And as you can see, the first and the largest group are those who presented clinically and who presented with liver failure. We've had 12 children present in this way, ranging from 5 weeks old right up to, rather surprisingly, a child of 2 years of age. Again, reflecting the ethnic balance in patients who have metabolic disease in Birmingham. Many of these are of Pakistani Asian background, and they all had positive urinary succinyl acetone, and subsequently we proved they had tyrosinemia by mutations, I think so. And again, nitisinone works extraordinarily well for this group of patients. We could see that their coagulation pattern, on the left, you can see their prothrombin time, or their measure of liver failure at the time of presentation. And within a week, almost all of these children had already shown a significant improvement in their liver function with the use of nitisinone and diet. And of those 12 children, 11 showed a complete response from the point of view of the management of liver failure. An extraordinarily successful treatment. And historically, as you've heard, 90% of these children would have died or required liver transplantation. One child in that situation didn't respond for reasons that are unclear to me, and he developed progressive encephalopathy, and he was rescued with liver transplantation 2 months later. So I think overall, for this presentation, for those who have acute liver failure, the commonest presentation of tyrosinemia in the non-screened population, NTBC is a remarkable treatment. More than 90% of treatment will respond. We would start all patients on NTBC, no matter how ill they are at the time, and we tend to use a high dose at the start just to make sure we get the level up very, very quickly. So we probably overtreat them a little at the start, but for a short time, I think that makes little difference. I think it's important in the acutely ill patients that we don't overtreat them with diet and give them too little protein, because that might make them worse. And we tend not to give them coagulation support, because it's very useful to us to know that if somebody's prothrombin time is 40 seconds, that we can see it coming down spontaneously, then we know the treatment is working. So we tend not to give artificial support. And in this situation of acute liver failure due to tyrosinemia, we would only consider liver transplantation if after a week of good treatment with NTBC, the clotting wasn't improvement, or, and this is again is very unusual, where a child had encephalopathy, or their brain was involved in their acute liver failure, or when they're deeply jaundiced. Because children with tyrosinemia who are deeply jaundiced tend to be very ill, and we would consider transplantation at an earlier stage in this group of children. Now, what happened to those children in the long run? Of course, we treated their liver failure, but they had presented clinically, so they all had some liver disease, and probably most of these children had at least fibrosis, and a significant proportion of them were already cirrhotic. Well, of those who responded, I did say 2 of the children who had complications, who were very preterm, died of complications of prematurity with their liver failure under control. But of the 9 long-term responders, they're now, the oldest of whom is age 23. We have actually had to carry out liver transplantation in 2 of those because we suspected liver cancer, which was a reflection of the liver disease that they had at presentation. In neither case did they actually have liver cancer, but we were concerned enough about it to liver transplantation. And 3 of them have cirrhosis and who are now aged 15 to 16 years of age. And we think they're likely to require liver transplantation at some stage in their life because they are cirrhotic. The next group are those who've presented with chronic liver disease. And again, overall, they have tended to show an excellent response to nitisinone. For those who've had one of the most severe complications of severe liver disease, which is portal hypertension, which is the tendency to develop high blood pressure in the liver and a risk of internal bleeding, that we find that 5 children had an enlarged spleen, which is a sign of quite severe portal hypertension. And with time, only 1 of those has splenomegaly persisted. So although they have advanced liver disease and they have cirrhosis and fibrosis, the consequences of this improves with nitisinone treatment. And we had 1 child who had esophageal varices, which are varices at the lower end of the gullet, which carry a risk of internal bleeding. And when we did a repeat endoscopy 4 years later, they had resolved without having bleeding. So although they have advanced liver disease, NTBC does something to improve. You get less consequence of that advanced disease. So it's certainly, we shouldn't be nihilistic about this treatment. Even when children have liver disease, we should use NTBC. The difficulty is, of course, the risk of developing cancer. And you've heard some of this already from the Quebec experience. I just show a couple of representative cases. This girl presented at 14 months, who had complex developmental problems, had heart disease, and had tyrosinemia. And again, her alpha-fetoprotein showed a dramatic response, but did not normalize. And this is what her MRI looks like. For those of you who are not radiologists, the white areas are lumps or nodules in her liver. Now, this is what she had when she presented. And the great difficulty for us in Manager, how could you possibly tell which of these nodules are cancer and which of these are nodules due to liver disease? And this is what her biopsy looked like. This shows dysplasia and cirrhosis. So she was clearly at risk from developing cancer. And in fact, eventually, once her heart disease was under control, we elected for an elective liver transplantation. And this is what her liver looks like. It's absolutely horrible with lots of nodules. But it didn't show cancer. All of these nodules were actually cirrhotic nodules, and we didn't find any cancer with her. Now, this is another case who presented, she underwent a liver transplantation. She's now 19 years of age. She's very well and is on 2 drugs and is growing normally. 15 years after transplant. This unfortunate girl presented again with liver disease at age 14 months in a non-screened population, very high alpha-fetoprotein, an abnormal scan, but just suggesting liver disease, nothing to suggest cancer at this stage, and her alpha-fetoprotein showed a gratifying response, but did not normalize. And unfortunately, we assessed her when she was 8 months of treatment, and we thought, well, we'll give the treatment a little bit longer. And in retrospect, that was an error. But unfortunately, for social reasons, this young girl got lost to follow-up and presented to us 6 months later when she now had developed bleeding from her stomach. And the reason she developed bleeding is that she had developed a large cancer in her liver, which was blocking up her portal vein. So, unfortunately, and her alpha-fetoprotein had shown a huge increase in size. So, unfortunately, this girl had developed a cancer, and rather unusually, it was a hepatoblastoma rather than hepatocellular cancer, which didn't look. So you can see the 2 extremes. In one situation, we were worried about cancer, and it wasn't there. In the other, we thought it was maybe under control, but in fact, very shortly afterwards, a cancer developed. So it's a very difficult dilemma. And overall, our experience in Birmingham with cancer in the NTBC areas We have one child who I've just presented who developed a hepatoblastoma, which is recorded in tyrosinemia but unusual, and she died. We have 7 of the 23 children who presented clinically who have undergone liver transplantation for suspected cancer. But cancer was only confirmed in 2 of those. And in both cases, we knew it was cancer before we did the transplant. It was very clear they had a single nodule or they had a very high alpha-fetoprotein. For those in whom we transplanted for suspected cancer, none of them turned out to have hepatocellular cancer. Now, that doesn't mean I think we were wrong completely, but it just shows how difficult the risk is. Histology, examining the liver, wasn't that helpful because we found that they all tended to show cirrhosis. We tended to find they had hepatocellular dysplasia. So histology wasn't very good at predicting. Looking at MRI, again, was useful. We found that those 3 who had cancers, they were 3 or 4 had one single nodule, which was more dominant, whereas those who had non-dominant nodules tended, that means where there was lots of nodules throughout the liver, they tended not to have cancer things. The alpha-fetoprotein tended to be classical in that one child at the time of presentation had a very high alpha-fetoprotein and there was clear radiological evidence of cancer. 4 decreased but didn't normalise. 1 normalised and then showed a secondary increase, and 1, very worryingly, showed a normal trend. And I think this has been referred to earlier. This is work from our Dutch colleagues, from Franken, who'll speak later. In general, alpha-fetoprotein has been a very sensitive marker of hepatocellular cancer. And in all the cancers we have found, the alpha-fetoprotein level has been high. But this rather worrying case from Holland showed the upper line is the child who developed cancer. And you can see that although the alpha-fetoprotein wasn't normal, it hadn't increased. And whereas we might expect after a decrease in alpha-fetoprotein that if a cancer developed that the alpha-fetoprotein would increase, we can't rely on that. And if we're using alpha-fetoprotein, we have to make sure that the level becomes normal before we can relax about the benefit of transplantation. So in those who present clinically and who have liver disease, there's always going to be some risk balance. The risk, if we don't do a transplant, is that we miss a cancer. The risk that we do a transplant is that we might have deprived somebody of a risk of life without transplantation. But it is an important philosophical discussion as to those who have liver disease, which is the best treatment for them. And this, again, is I think, finely poised. For transplantation, children and adults can eat a normal diet. And that is, I know our dietitians do make huge efforts to make the diet palatable, but there's no doubt this does not compare with a normal diet. We know the risk of cancer doesn't go away. The drugs are less costly after transplant than with tyrosinemia. And something that's been referred to for the younger women, of course, we have much more experience of young women having pregnancies after transplantation than we do have with nitisinone. So again, for those who presented with liver disease, who are at risk of cancer, it is a fine balance to decide which is the best treatment. And it's a decision to have an individual discussion on. So I think where there is chronic liver disease, if NTBC has not been started in the first months of life, we have a risk of cancer. We have to monitor these patients very, very closely. And it's not risk-free, because by the time malignancy might be detected, it may have already spread. So it's a very hard balance. So overall, of those 11 patients who presented with chronic liver disease, 10 of them were surviving, of whom half have had liver transplantation. But only 2 of them actually had proven cancer at the time of transplantation. But all the others are surviving very well with liver transplantation. I'd like to, however, say that it's not all dark in the management of tyrosinemia in the United Kingdom. We do have 12 patients who have been treated almost as if they've been born in Quebec. They've been screened in the newborn period and treated with nitisinone since life. And I am very confident that their risk of hepatocellular cancer in the long run is very, very low indeed, so long as they remain compliant in adolescent life. Thank you very much.
Des questions?
Frank Jan Vosbrons in the Netherlands. Pat and your colleague, could you have an answer on the question whether we should be really afraid of hepatocellular carcinoma in patients screened for tyrosinemia, so starting within 1 or 2 weeks with NTBC?
Well, obviously, I think because this is a relatively recent development, I think we need to be conservative and monitor them carefully. But having seen that and looking at the Quebec experience, I think we have prevented them developing liver disease, and I think we've changed their disease. And I'm confident that their risk of cancer in the long run is very low. But of course, their defect is lifelong. And as somebody referred to them, our teenagers are not always so good at doing what we tell them. So that risk, if they're non-compliant with their treatment, will persist throughout their life. But I believe if they're compliant with treatment, their risk of cancer is very, very low. I hope I'm not hopeless optimistic.
And does that mean that you have a different protocol for your patients with ultrasound and MRI?
Not formally. I think it's drifting that way, Frank. And I think it was things. I think we're not quite brave enough to do that yet, but I think we will as we build up time. And I have to say that I would be personally comfortable in stable, compliant patients moving to an alpha-fetoprotein monitoring things in stable patients in later life. But we haven't done that yet, and it's probably a little too early to do that yet.
Thank you.
Excellent. Over there.
Hi there, Burke.
Hi.
Burke from Canada, from British Columbia. My wife and I have a daughter who's almost 2 years old with tyrosinemia, and she is on nitisinone. I have 2 questions. First one is for children that have received a transplant, how does their immune system keep up? I mean, our daughter has not had a transplant, but with a transplant and on immunosuppressants, how is the immune system still functioning? Second question, very quickly. The alpha-fetoprotein, we've learned a lot about succinylacetone and the dangers there, but the alpha-fetoprotein we don't know a lot about. So what kind of levels are normal for AFP?
It's the first question first. Immunity is not normal after liver transplantation because liver transplantation requires you to take immunosuppression for the rest of your life. But for functional patients 5, 10 years, 15, 20, 25 years after transplant it causes little functional impairment to their life. And one of the very pleasurable parts of my life is seeing children with tyrosinemia who've been treated from screening, but also seeing the long term after transplantation. For the vast majority of people, this is a very successful long-term life. But it's not 100% cure. There is a mortality with liver transplantation, and that's why we take cause to take a break. Is it indicated? And for many patients, I always say, successful liver transplantation is the best treatment for many metabolic conditions. But of course, can't completely guarantee it will be successful before the start. But the long-term functional outcome of liver transplantation is very gratifying and very satisfactory. The second question about alpha-fetoprotein, it's lab-specific, but it's usually less than 10 is the cutoff point. But obviously this is age-specific, and it's very high in the newborn period and takes time to come down. But usually about 10 is depending on the laboratory.
Okay, thank you.
Over there.
Joanne Harvey, pédiatre à Chicoutimi. Here.
This side.
No, because he was looking to where it was the question. Do you have any experience with oral contraceptive? Would it be for NTBC and anyway with tyrosinemia? Is it a contraindication? Because some hepatic disease are some different minor disease are, even though we know that there's a metabolism in liver cell. Do you have any experience?
Yes, I think as long as somebody has stable compensated liver disease and there are no nodules in the liver, oral contraception is absolutely fine. It's best to stick to the progestogen only or a low dose estrogen one where possible. But as long as there are no nodules, it's a little more difficult with nodules. And I think in that situation you do need to monitor things a little more carefully. I have no personal experience with the contraceptive pill in young girls with tyrosinemia, but I don't think, and I'm looking to the metabolic physicians here, I don't think it will have any effect on the tyrosinemia itself. But from the liver disease, I would be, so long as they have no nodules, I've been happy. And Dr. Mitchell is also nodding to suggest it shouldn't have an impact on the metabolic control either.
So it's important for the people who are following them beside their disease to get the results of those exams then?
That's right. That's correct.
Okay, last question.
Yeah. Thank you for that presentation. I am Aditya, a parent of twins from India with tyrosinemia. I have 3 questions for you. One is, how long would you give the alpha-fetoprotein to normalize after it is initially elevated? The second question is, in case of the children who go on to develop the cancers, is it just the transplantation, or do they also require some form of chemotherapy before you transplant them?
Yeah.
Okay, the first thing, it depends. It's age specific. If it's a newborn child or if it's a young child, I think you can safely wait for 1 year, so long as the alpha-fetoprotein is shown a logarithmic decrease. Thing. Outside it depends on the context, and I think you'd also want to know what age the child was and what the liver looks like, whether there are nodules. So it's a thing. But in general, you'd expect the alpha-fetoprotein to have close to normalized within a year. But it also depends on the rate of decrease. And I think Frank and his team have shown that slow decrease in alpha-fetoprotein is a worry, because that suggests that this is a liver more at risk of developing cancer. For the second question, if it's hepatocellular cancer, HCC, then chemotherapy doesn't really have much of a role, and surgical treatment is the defined treatment. We sometimes use chemotherapy, but I think surgical treatment with transplantation is the definitive treatment for hepatocellular cancer. Hepatoblastoma is very different, and hepatoblastoma has been described a couple of times in tyrosinemia, and it's exquisitely chemosensitive, and we would use chemotherapy and then do transplantation at a later time.
You mentioned one patient with HCC and disseminated disease. Is that...
Yes, we had, our young man who was transplanted, who developed, he was age 13, he'd been 10 years on NTBC, developed a cancer, and it was very rapidly developing, and at the time of his transplant, it was clear there had been vascular invasion, and he got recurrent disease 2 years afterwards, which was with a pulmonary nodule, but in fact, that was successfully resected, and now 10 years later, he seems to be cancer-free. But it is difficult, and a very hard risk-benefit balance, because if you do it too early, you may deprive somebody. If you do it too late, the cancer may have already spread. But HCC due to tyrosinemia, I think, is biologically different, and I think that you can salvage patients at a later stage. If I, at my age, had hepatocellular cancer, like some children with tyrosinemia get, I wouldn't be treated because it would be too advanced. But I think there's something biological different about what happens in younger people, that they do respond to aggressive treatment slightly better.
Yeah, and the last question, I may be wrong on this, is NTBC also known to cause some liver dysfunction by itself?
I don't think so. And as far as I know, in the alkaptonuria patient, there has been no description of liver disease due to this. Obviously, it's very hard when it so successfully treats liver disease. It's quite hard to pick up liver toxicity. But in the alkaptonuria, I'm not aware of anybody who's got liver dysfunction.
Thank you.
Thank you, Dr. McKiernan.